Hello, my name is Dr. Jacob Sexton. I'm one of the new primary care sports medicine physicians here at Children's Health Andrews Institute. Quick background on myself. I am originally an athletic trainer, graduated from Troy University, followed up my medical school at the University of South Alabama in Mobile, Alabama. My residency training was in emergency medicine in South Carolina, and then did my non-operative primary care sports medicine fellowship at the Andrews Research and Education Foundation in Pensacola, Florida last year. Today we're going to be talking an introduction lecture on what is musculoskeletal diagnostic ultrasound. Quickly, for disclosures, I have no disclosures for this lecture and no financial interest. For the objectives, we're going to review some common ultrasonography terms and their applications in musculoskeletal medicine. We're going to then focus on differentiating the different tissue characteristics of certain anatomical structures. We're going to briefly discuss the diagnostic and therapeutic applications of ultrasound in musculoskeletal medicine. And then finally, I'm going to demonstrate some ultrasound pathology and kind of those clinical applications and how these can be used in the management in sports medicine and rehabilitation. So quickly talking about musculoskeletal ultrasound, the big question is, well, what are the advantages and what are the disadvantages and why would I use it over plain films or why would I use it over MRI, CT scans, and other diagnostic imaging modalities? The real big thing for me is the fact that you get real-time patient feedback. So this is a dynamic ultrasound and dynamic study in real time where you're actively moving the patient and actually palpating the structures as you're performing ultrasound. So the patients are allowed to give you feedback during that time to tell you exactly where things are hurting and where things are not hurting. And we'll kind of give you more confidence in pathological findings when you find them. Again, images can be done both statically and dynamically. So you can move patients through range of motions of the joints, through different arcs, observing movement of tendon structures and those type things to see if there's any pathology associated. Using diagnostic ultrasound, it helps improve procedural accuracy as well as instrument guidance when performing any kind of procedures, particularly corticosteroid injections, hydrodissections of nerves and other procedures such as that. The biggest benefit probably, or one of the biggest benefits, it does not involve ionizing radiation as opposed to CT scans and X-ray and plain films. And then finally, the machines are becoming so functional now that they're becoming portable. And so they have potential sideline and athletic training room and outside the clinical office applications. The big disadvantages for them, though, is it's operator dependent with a very high learning curve. It takes multiple years to become proficient in diagnostic ultrasound. And currently at this time, I'm still in the phase where I'm learning something new every day in order to improve my skills both diagnostically and procedurally. The other limitation is, and we'll talk about this when we get to the physics of ultrasound, it is limited in evaluation of deep soft tissue structures or intra-articular structures, given the inability of sound waves to pass through hard surfaces such as bone. It's also time dependent. It does take a little bit more time in the examination room. So you got to make sure that you have time scheduled for those patients. And then it's also machine dependent. You kind of get what you pay for. The better machine, the better the image resolution, the more bells and whistles you have on it, the less you pay for it. Image quality is sacrificed a little bit and you won't have some of those additional applications. So this is a quick view, just different ultrasound types. The one on the left is one of the current ones that we have just received. One in the middle is kind of more your traditional musculoskeletal ultrasound machines. And then one in the top right corner is the Butterfly IQ ultrasound that's portable, that is having utilization in kind of the athletic training room and on-field sideline management. So what exactly is ultrasound? So ultrasound is creation of images on screen by utilizing the piezoelectric effect. The piezoelectric effect is the transition of electrical energy into mechanical energy and the mechanical energy to electrical energy and vice versa. The sound waves ultimately return back to the machine and then are turned into images in gray and black scale using those sound waves as opposed to ionizing radiation. So in the bottom left image kind of shows a good example of how this works. The ultrasound machine sends out an electrical current signal that approaches these pink squares, which would be considered the ultrasound transducer crystals in this example. They expand and contract in response to that electrical stimulation and then subsequently produce sound waves that go into the tissue. That subsequent mechanical energy from the sound waves then strikes particular surfaces such as a bone, tendon, skin, and other structures and is either absorbed or reflected back to the probe. Once it's reflected back to the probe, it enters the crystals again. The crystals expand and contract, and that mechanical energy is subsequently converted back into electrical energy back to the ultrasound machine where images are subsequently created. So how do we acquire an image for ultrasound? How we do it properly? The first way to optimize image acquisition is having a proper coupling agent. So acoustic waves must first pass through the air and skin before they interact with other soft tissue structures. If you can imagine, sound waves will want to bounce anywhere they go and don't follow a uniform pattern. So you use an acoustic medium such as gel, water bath, or that glove on the bottom right image to provide a medium for those sound waves to propagate and penetrate so they don't get lost into the environment. This also allows for more efficient contact with the skin surface and well optimizing your image quality. One of the things that learned very early on in my training, and the more I've used it both in the emergency department and the sports medicine world, is you can never have too much gel. If you feel like that you haven't put enough gel on there, you should put a little bit more gel in order to improve your quality of your image. So how does this look using, traditionally we use gel and those type things. So how does it look when you do it to optimize your image for these very superficial structures and those type things? So the image on the left is a long axis image, which we'll discuss in a minute. It's a picture of the metatarsal phalangeal joint. And above it here, you have this nice skin surface right here. And then sitting above that is nothing but acoustic gel. And this is called a standoff. And we do that in order to visualize superficial structures and other structures also that is very bony, has a very varying contour on the bone in order to allow the standoff to allow those sound waves to hit the structures and optimizing your image. You can also use a water bath, which is an image on the right side. So this is just an 18 gauge needle placed in the water bath. You have this nice black acoustic medium, which is the water that sound waves go through. They'll extract the reflective surface and then go deeper. And so this is useful for superficial structures such as the hand, the digits, and the feet. So next we talk about the ultrasound transducers. So ultrasound transducers are described by both their frequency and by their footprint. So higher frequency probes are usually more linear in nature. They have a higher resolution, but they give up the expense of penetration. So the top right image is a traditional linear transducer probe, and you can tell the frequencies by the numbers on it, such as this one's L4, 12T, which demonstrates it has a frequency between 4 and 12. The bottom middle one, C15, has a frequency between 1 and 5. And then you have the hockey stick, which is kind of an upgraded version of the linear probe with even higher frequency of 8 to 18, and kind of vice versa. So probes that have a lower frequency allow for deeper tissue evaluation, but you sacrifice image resolution in that standpoint. So it's very important to understand what anatomic structures you're looking at, which will determine what probe you need. So quickly talking about these two images here, on the top image, we have a curvilinear probe ultrasound image, and at the bottom image, we have a linear probe. The easiest way to kind of look at it on the image, if you're not sure which one you have on screen, is it'll kind of tell you your footprint when you look at the top of the image. You see here he has a nice curved acoustic window and kind of fans out almost in a trapezoidal type pattern. And that lets me know this is a curvilinear probe. While the bottom one, you have this nice flat top transducer probe image, and you can see it propagating directly down almost in a square, which lets you know we're in more of a linear probe footprint. So whenever we're talking about diagnostic ultrasound, it's good that we use the same terminology when we talk about how we're moving the transducer probes in relation to patients and when we're talking to our colleagues about what we see on our ultrasound image. This is a image that was provided by a recent consensus by the American Society of Sports Medicine and other ultrasound professional societies who kind of tried to make a consensus statement on what's the best terminology for these movements. And so briefly going over that, slide is just anytime you're moving the probe. It doesn't matter if you're moving medial to lateral or proximal to distal. If you're moving the probe and sliding it over the surface, it's just called sliding. Heel to toe maneuver is sometimes mentioned in ultrasound as well. That's whenever you have the probe in its long axis, so long ways, and you're rocking the probe from left to right. And sometimes you do that in order to capture images that are kind of at an angle, or also to eliminate artifacts, which we'll talk about in a little bit later in the lecture. Tilt is the same kind of process, but instead you're kind of rocking it back and forth more on its short axis at that point in time. Same thing in order to capture image acquisitions at abnormal angles or to try to catch pathology you can't quite see in certain locations or those that have deep curves or deep bony structures that you can't get around. Compression is pretty simple. Compression is whenever you take the probe and you push down on top of the patient's tissue. Rotation and pivot are kind of the same definition. It just means that you're twisting the probe either clockwise or counterclockwise in a fixed position. Standoff, as we mentioned earlier, is whenever you use an acoustic medium such as gel to stack up, and then you kind of let the probe lie on top of that. And it's more to allow separation of surface between the ultrasound transducer and the image structure that you want to see. Usually done more for procedures if you have a steep angle that you need to approach the needle with, or if you have a very superficial small structure that putting probe pressure directly to the skin can obscure your image. So how exactly do ultrasound waves interact with tissue? So on the left image, we have transmission, and this is most commonly what's described with these ultrasound waves. Transmission is just propagation of the waves without reflection. So if you can imagine the yellow box being the ultrasound transducer, the red lines being the sound waves leaving the ultrasound transducer, and each of these blue lines representing barium and soft tissue structures in no particular reason. Transmission is just the propagation of those waves through barium tissue structure without impedance. On the other side, you have reflection, and this is how the images are created. So as sound waves come down from the transducer and they strike a surface, they can either be transmitted and continue on, they can be absorbed by the tissue structure itself, or they can reflect off that tissue structure and then come back into the transducer to help generate your ultrasound image. Understanding that all waves will not be propagated in each different tissue structure, such as air, bone, lung tissue, tendons, ligaments, will each have different absorption and reflective capabilities, which we'll discuss in a few slides. So refraction is one of the things that happens during the process of taking images. You'll never receive 100% of the sound waves that you send out. Like we talked about, some get propagated through the tissue, some get absorbed into the tissue, and then some end up going off a separate angle from where they arrived. Instead of returning back to the transducer probe, they're reflected off away from the transducer imaging surface, and therefore will be lost to the study. And you limit that by having appropriate contact with your acoustic gel, making sure you're maintaining perpendicular probe to tissue structure contact, and optimizing your image quality. And then attenuation, as we described earlier, attenuation is decrease the intensity of the sound waves as it passes through a medium. So as you can imagine, as it goes through each tissue interface, you're going to lose a certain number of sound waves with each one of those. And then eventually the penetration cannot go any further. And that's kind of at the end range when you get down to the 4, 5, 6 centimeter mark for most anatomical structures. And then remember that refraction, attenuation, and absorption all limit ultrasound ability to help evaluate those deep tissues or bony structures beyond. So as with other imaging modalities such as MRI and plain films and CT scans, whenever you're taking an image, you're taking a 2-dimensional image and a 3-dimensional structure. So we describe this in ultrasound whenever we get images of both long axis and short axis. In order to limit false positive examinations, in order to determine true pathology, we typically like to have images in both short axis and long axis in 2 views in order to ensure there's no artifact or any false positives that would interfere with our study. So anytime that you imagine long axis, look in our image here, long axis just means that if you could imagine this being the tendon structure, this red cylinder, we are just cutting through the image in its long axis. There's long cut. As you can see here on the left image, this will correlate to the Achilles tendon coming down through here in long axis as it's coming down and inserting on the calcaneus right here. Short axis is literally just turning the probe transducer 90 degrees. And at that point in time, you're cutting the structure in half at that point in time, and therefore it's short axis. As you can see the red cylinder here with your transducer beam coming down and cutting that structure to a single spot right there. And this is the same exact image on the bottom image as compared to the top image, just rotated 90 degrees in short axis. So you can see how the long axis has a long aspect of the tendon, and the short axis, you're catching more of the fibrillar bunch pattern from the short axis view. And then remember, pathology typically must be seen in both short axis and long axis in order to limit false positive examinations. So the next thing we talk about is the echogenicity of a structure. Echogenicity is basically a structure's relative ability to transmit or reflect sound waves. So the more echogenic, so the more hyperechoic or more white the image is, the more likely it is to reflect sound waves back. While structures that have very low density, such as blood, air, some muscle structures, are less echogenic and more anechoic or black and allow more transmission of sound waves to deeper structures. So when we're talking about this, anechoic kind of typically means black on the ultrasound image, and hypoechoic is kind of a dark black, light gray type of color. Then you move to isoechoic, so more of a gray type structure. And then you move ultimately to hyperechoic, where it turns bright white on the image. And the top image does a great job of kind of describing all of those in a structure. So coming across here from left to right, you have the brachial artery coming across here. It's got a mostly hypoechoic. There are some isoechoic components in here. So I know this is a vessel, most likely. And so following underneath that, you have a fascial lining separating that. And then you have this striated structure through here. This is the brachialis muscle. So as you can see, this would be hypoechoic to this isoechoic gray area of the muscle. And then you have these white stripes coming in through here. This is adipose tissue within the muscle, which we'll talk about a little bit more in the lecture. And then further down here, you can even see the articulating cartilage of a hypoechoic cartilage, followed by the bony structure, which is very hypoechoic on this image. This bottom image also shows the difference when you get a very hyperechoic structure and you attempt to take an image through it. So this is the tibial cortex coming through here. And this is an artifact, which we're going to discuss in a minute. But once you get a very hyperechoic structure, all the sound waves are reflected afterwards. So there can be no more propagation into deeper tissues. And like we said earlier, this really limits our exam for intra-articular structures, such as like the ACL and PCL and some of those things deep inside the hip. So when we're continuing to describe ultrasound images, there's two additional things that we can do to optimize our image, and that's controlling the depth and the gain. Depth is pretty self-explanatory. It's just how deep you're allowing your image focus, capture image on your screen, while the gain adjusts the overall brightness of the image. So this is two images of the antecubital fossa here. It shows a great example of how depth is important in diagnostic ultrasound. So the image on the left is an optimal depth for this study. In particular, I was focusing on the median nerve at this point in time. So there would be this structure right here. I have some hypoechoic elements here, likely representing blood vessels. I also know that this is cut in half. It looks like it's short axis. So I know it's a short axis view. It does an excellent job of coming down through here, and I see all the anatomical structures I need to see. As here we have the distal humeral cortex coming along through here, the humeral articulating cartilage, and followed by the muscle tissues above it. And as you can see, this is the bottom of my image capture on this side here. And so I'm not wasting and not utilizing any of my ultrasound image space. Usually images are measured in centimeters, and it's usually located on the right side of your image capture on your screen. As compared to this right image here, this is the exact same photo. All I did was increase the depth to its maximum. And as you can see here, you still have a pretty good overall quality structure as far as your brightness and being able to identify the structures. But you can see it zoomed out because we are sacrificing about 1 centimeter of image space for pure nothing. Because as we know from the previous slide, that sound waves are not going to be propagated through this hyperechoic bony cortex. So therefore, we need to optimize our image to make sure we're focusing on the structure that we want and limiting that dead space. So as opposed to depth, gain is discussing the brightening or darkening of your focused image area. So this is making sure that structures supposed to be black appear black, and that structures that appear white are supposed to be white without overemphasizing those structures. So the far left image kind of gives a good example of what we call undergaining. So I know it's the antecubital fossa because I have the humeral cortex here. It looks like the median nerve sitting there, and I have some vessels here. but it's overall very black. I do know that this is a muscle tissue here, but I'm not seeing the good white striations I would expect in the structure. So let us know this is very undergained, and I wouldn't be able to get much quality information from that. As opposed to the right image here, now we've overgained it. So all the structures that are supposed to be hyperechoic are hyperechoic, but so are the structures that shouldn't be hyperechoic. So you can see here, the vessel walls are very highlighted here, and you can almost see that it's causing artifact that within the vessel wall. So you're starting to get some isoechoic elements and a little bit of hyperechoic elements within the vessel walls. And then you have your median nerve here where you're having difficulty distinguishing its individual nerve fascicles here because it's overall too bright. And so then what you want to look for in optimal gain on your ultrasound images, you want to make sure that your black structures are easily identified, so your anechoic structures. You want to make sure that your hyperechoic structures are easily identified and that they have a nice scale in between and that you're able to identify the isoechoic or gray structures pretty readily. So this is what you're looking for if you want to consider an optimal gain image. So next we need to talk about artifacts briefly. So artifacts are image features formed by reflection and backscattering of ultrasound waves, resulting in image discrepancies. Most classically, the ones we see in musculoskeletal ultrasound, although there are many more than this, are acoustic shadowing, reverberations, and anisotropy. It's important to understand the acoustic artifacts because sometimes we use them to our advantage and sometimes they use us to our disadvantage whenever we're taking diagnostic ultrasound images. So acoustic shadowing is pretty straightforward. This occurs when an echo-free shadow is created when sound waves are unable to pass through a solid or hyperechoic object. Most classically, this is described with bony structures as well as intra-abdominal structures such as gallstones. So on the left image here, you have a picture of the radius. The radius is in short axis, so you can see it being cut in half. And this is the contour of the hyperechoic radius here. As you can see to the left of it and to the right of it, you can see continued propagation of the sound waves down into the deeper tissue structures, okay? And then over the bone area here, this is a different artifact, which we're going to talk about in a second. But you notice through here how it's turned completely black distal to this area or deep to this area. So that's an example of acoustic shadowing, all right? This, on the left image, this is an example of a gallstone within the gallbladder, and it shows an excellent example of acoustic shadowing. So you have a sound wave going in that's striking this very hard, very solid hyperechoic calcium structure, and therefore sound waves are not able to propagate any further. The sound waves that are hitting that are being reflected back to the transducer. So therefore it creates this artifact or shadowing behind it. We know that there's something behind there. There's just not an empty space. We know there's tissue behind it. It's just the ultrasound's not able to recognize it, giving the artifact. And this is an example of that from here. Imagine this being the ultrasound transducer, these being the propagated sound waves, both laterally and medially to the hyperechoic structure, with sound waves getting bounced back immediately and reflected back to the transducer without propagation. So next is reverberation. Reverberation occurs when sound waves strike a reflective parallel structure. It creates a series of reflections to the target tissue that are uniform in appearance. Most commonly, this is going to be seen with very hyperechoic structures such as bone and instruments that involve metal, as well as foreign bodies such as glass or other structures within the body. This can also be observed in lung tissue. So on the bottom, on the left image here, we have the 18 gauge in our water bath that we showed earlier that demonstrates excellent reverberation artifact. Once the needle is parallel to the probe, you get the initial image of the needle, and then you get this reverberation. It's a uniform, similar in appearance, pretty much follows the same exact spacing and pattern. And all this is just reverberation of the artifact from the machine not being able to understand exactly what's going on there when it's trying to absorb or when the sound waves are being absorbed and reflected. As opposed to this right image, this is when we use ultrasound to our advantage with artifacts. So this is a lung tissue or pleural image. So you have your rib here, you have your rib here. This is the intercostal space. You have your muscle tissue through here. And right here is the pleural lining, okay? So this is the only pleural lining that would normally be seen. Anything deep to that's going to be air tissue, okay? What happens though when you have this highly reflective surface, it hits that fascia plane, bounces back into the ultrasound probe. You then get this reverberation artifact down here that demonstrates almost like there's a second pleural lining, which when in fact there is not. And then again, you can see another one trying to show up there. So that's what we use, and this is what we expect to see in a lung tissue. So this is an example of how we use artifacts to our advantage. Finally, and most importantly for musculoskeletal imaging is probably anisotropy. So anisotropy occurs when sound waves are reflected away from the transducer, therefore making hyperechoic structures appear hypoechoic. It is a result of increased oscillation angle of the transducer sound beams. And I believe the best way to describe that are those two images on the right. So you have your ultrasound transducer here represented by the blue box. You have your ultrasound beam being represented by the gray line here. So anisotropy is best reduced when the ultrasound transducer is perpendicular to the target tissue in question. And if you can imagine, most of your sound waves are going to reflect back into the transducer at that time. You're going to have limited refraction and loss of image waves. You can imagine by tilting that probe just even a little bit, 2 to 3 degrees from perpendicular, you're going to create an inclination angle that's going to be allowing the ultrasound sound waves to bounce and refract off into a different location, therefore limiting the amount of energy returning back to the transducer, overall resulting in poorer image quality. And this can be best described here on these left images. So this is an example of anisotropy. If I looked at that without any other context, I'd be like, hey, I have a very hypoechoic structure here. It could be a tendon, it could be a ligament, exactly what is it? But it shouldn't be this hypoechoic in appearance. But you can correct it by placing the transducer in a perpendicular to that tissue, and then suddenly you see this nice fibrillar pattern, compact pattern that is seen with your distal Achilles tendon. And then remember, minimum anisotropy occurs when the transducer beam is perpendicular to the target tissue. So this video clip right here is an excellent example of anisotropy. So what you're going to see at the beginning of this image is the hypoechoic area of the Achilles tendon. And this is when the probe is very tilted. And then as the image progresses and the clip progresses, you're going to see the nice fibrillar pattern of this Achilles tendon and short axis show up. And then I'm going to keep tilting the probe, and then you're going to see recurrence of this anisotropy. So this is an excellent example of this artifact that we see on ultrasound. So again, I'm going to get a hold of this and kind of show you a little bit. So again, got this hypoechoic area. And then as I continue to tilt the probe, I have correction of my anisotropy, with it being almost eliminated there and having a nice fibrillar pattern of the Achilles tendon. And then as the clip goes and I continue to tilt the probe further on, it then turns back into that hypoechoic area. And if you're not aware of anisotropy, it can make you think of a pathological lesion, just a strain or tear, when there's actually one not there. So now we're going to discuss briefly what do different anatomical structures look like under diagnostic ultrasound. So first we're going to start with tendons. Tendons, for their normal anatomy, they're going to be a compact fibrillar network and long axis. And short axis, they're going to bring on that bunch broom appearance. It's predominantly hyperechoic with all of the, which actually has the collagen and elastin components. And then it's interspersed with the hypoechoic elements, the endotendineum septa, which does have the blood supply and the neurovascular components within the tendon. The other thing when thinking about tendons, and whenever you're initially starting with diagnostic ultrasound, you're like, I think I'm on a tendon. How do I know if I'm 100% on a tendon? Just trace it back to its bony origin or its bony insertion, and that'll let you know that you're correctly on a tendon. And then you can follow it out to its musculotendinous junction to follow along into the muscles if you're having difficulty in finding your home base. So the top left image, again, I know we've seen this one a few times, but it's just an excellent example of what a tendon looks like, normal tendon looks like. So I have a long axis view here. We have a nice compact fibrillar structure going from left to right through here. So I know that this is most likely a tendon. I know it's also most likely a tendon because in long axis it's going and attaching to a hyperechoic structure. I know this is a bone, given that it's very hyperechoic, and then it develops acoustic shadowing artifact underneath it. There is a little bit of anisotropy also on this image. As you can see, you have this normal fibrillar compact network, and then it turns hypoechoic and anechoic in this area. If I was to do a heel-toe maneuver and correct that anisotropy, then it would turn into a normal fibrillar network. Now on the right image, I have a nice view of the Achilles tendon in short axis again. So I know it's short axis because it has this bunch broom appearance where they're all bundled together. It's very nice, compact as well. And there's very limited anisotropy on this image because I know it's very uniform in appearance. I don't see any defects or abnormal echoes. So that's what a normal tendon structure appears, as opposed to ligaments. So ligaments are more hyperechoic than the tendons are. And that's because they have less of that endothelium septae. They have fewer vascular and neural elements that can be seen on ultrasound as compared to tendon structures. So it's going to have the similar appearance to a tendon. It's going to be more compact. And the other thing that you'll know whenever you start practicing and you're working on these images, you know you're on a ligament structure when you have a nice compact fibrillar structure that's connecting two bony surfaces, because we know that's what ligaments are functioning for. So the image on the left shows a nice example of the ulnar collateral ligament. So you have the nice contour of the humerus coming down in ski slope pattern, comes across here. I have the humeral ulnar joint sitting right through here. And then I have the sublime tubercle of the ulna developing right there. I have this nice fibrillar, very compact structure going right through here that's originating from the medial epicondyle, that's coming across the joint and attaching to that sublime tubercle. So this is the ulnar collateral ligament, okay? As opposed to up here, you have the common, I'm catching a kind of an oblique angle, but this is a little bit of the common flexor tendon with its transition into its muscle bellies right here, from the nice fibrillar compact tendon structure to the muscular structures here. And you can compare that to the image on the right with that Achilles tendon. You can see there's a little bit more hypoechoic elements as compared to the pure hyperechoic element of that ligament structure. So in regards to muscles are predominantly hypoechoic. They have interspersed hyperechoic bands. The hypoechoic or isoechoic regions represent individual muscle bundles, while the hyperechoic areas represent fibroadipose septo or the perimyesium. So that's where all your adipose components are, your fascial layers, and those part of the muscle are located at. So this image here demonstrates a muscle in long axis. So this is the gastrocnemius soleus complex here. I have superficial skin structures coming through here. And then I have this nice big, almost looks like a slab of steak to me. It's very nice and hypoechoic with some hyperechoic elements kind of interspersed with it. You have a fascial lining sitting right here, separating the gastrocnemius from the soleus complex. And then deep to this, I have the deep vascular structures of the posterior compartment, including the posterior tibial artery and vein system. As opposed in short axis, looks pretty much the same as it does in long axis. You're expecting to see a nice hypoechoic with interspersed hyperechoic elements. And then you'll have these different very hyperechoic bands that help separate individual muscle bundles and separate muscles from one another. Whenever I'm thinking of muscle tissue, I think of kind of a time lapse of a starry night sky. And that's what I'm looking for, kind of this bottom right image. I know when I'm seeing that pattern, I'm looking at nice, healthy muscle as opposed to any strains or any other deficits. Now, for vascular structures are pretty easy. They're best visualized in short axis, and when I'm evaluating them in the musculoskeletal standpoint, is predominantly for IV placement, as well as to assess whenever I'm fixed to perform a procedure to make sure I'm not getting close to any of these important vascular structures. They're pretty easy to distinguish under diagnostic ultrasound. So the top left image is representative of an artery. So you can see it's nice and pulsatile. It's not easily compressible. It has a nice vascular wall that has a nice hyperechoic ring surrounding that isoechoic vascular structure. While on the right image, I have a vein here. So again, I have a nice hypoechoic circular structure that lets me think I'm in a vessel. The big difference is when I press down and compress on the area, I have complete compression of the veins as opposed to the artery, given the pressure behind it will not allow complete closure on ultrasound. And that's one way to help distinguish between the two. And the other way to distinguish between the two is using Doppler ultrasound, okay? So Doppler is one of the many tools that we have in our disposal, and we use it for other conditions such as assessing for tendinosis, assessing for any increased neovascularity and chronic Achilles tendinopathies and those type things. But it can be used for letting us know, are we looking more at a pulsatile arterial structure or more of a static flow such as a venous structure? The blue and red colors on Doppler do not indicate that it's an artery and a vein. It just indicates which way is the sound or the flow coming, with red representing coming towards the probe and blue representing sound waves going away from the probe. So this image on the left demonstrates an excellent example between static flow. So I have a nice, smooth, static flow without any pulsatile elements to it. So this lets me think most likely a vein, as opposed to these two structures right here that you can see has a nice pulsatile beat to it that most likely represents an artery at this stage, and then probably a little vein attached to there. Now, this image here, nothing really special about it, but if you pay close attention, you can actually see the isoechoic blood actually moving in the posterior tibial vein. And I'll kind of pick it out to you once we get it started. So if you look here, there's the posterior tibial artery coming through here. And if you look through there, eventually you'll see some very subtle hyperechoic structures. And that's when you actually see blood moving within the vessel. And that's one of the ways we can help use diagnostic ultrasound whenever we're evaluating for vascular injuries such as deep vein thrombosis. So continuing on, looking at peripheral nerves at this point in time. Peripheral nerves are one of the more difficult structures to get a good view on ultrasound with, because usually they're pretty small. It's very hard to get a nice targeted focus area in it. It's usually surrounded by other vascular structures. And then they'll branch off into their, even further branches. And it just makes it very difficult because you're looking for like one small neurovascular neural bundle disposed with all these tissues. The next structure we're going to be talking about are peripheral nerves. So peripheral nerves are probably one of the more difficult structures to identify on diagnostic ultrasound. They're typically very small. And then when they start branching into their subsequent distal branches, you're sometimes looking for a single neural fascicle, which makes very difficult to use when attempting diagnostic procedures such as hydrodissections or just evaluating for any compression or neuropathies type thing. So in long axis, the peripheral nerve is going to take on this tram track appearance here. So this is the superficial portion of the median nerve right here. This is the deep portion of the median nerve right here. I have above it muscle tissue here that's turning into its musculotendinous junction. So it's turning into a tendon at this point in time. I have another muscle underneath here that's turning into its musculotendinous junction at this time. And then I'm catching these kind of more of a short axis view for these muscles. So classically, peripheral nerves in long axis are going to be this tram track appearance, while those in short axis are going to bring on more of a honeycomb type appearance. If you can look at this picture here and then kind of represent that, you can see kind of how it takes on that nice honeycomb appearance. You got this nice little hypoechoic circles within representing each neural bundle, with the hyperechoic elements represent the blood supply and the fascial covers of the invendible nerve, while the entire structure here being the nerve. So this is the median nerve here. And I know I'm kind of in the mid forearm area because it looks like I got the palmaris kind of developing through here. I got a little vessel supply here, and then I have my hyperechoic bony structure sitting below that. And then finally, talking quickly about bone tissue. Bone's pretty easy to identify on ultrasound. You're looking for a very hyperechoic structure that will not allow propagation of sound waves any deeper. You're also routinely going to get that reverberation artifact or acoustic shadowing, depending if your probe is parallel or not to the image study. So on the left image, I have the distal radius and long axis. So this is the actual radius bone right here coming all the way across. And then I have the superficial soft tissue structure sitting here. And then deep to that, we talked about earlier, reverberation artifact is going to develop that nice uniform appearance. So, approximately 1 centimeter down or half a centimeter down, I have another nice hyperechoic band coming across. And then approximately another half centimeter down, I have another nice hyperechoic band going across. So I know that my probe's in a nice parallel position. I know it's a good image because I'm getting the whole contour of the bone and I'm getting the appropriate reverberation artifact deep to it. as opposed to this image here. So this is the exact same radius. Now I'm just turning in short axis here. So again, we have a nice hyperechoic structure coming across here with deep acoustic shadowing on this side and acoustic shadowing on this side. And where the cortex is exactly parallel to the transducer receiver, we're getting that reverberation artifact even better on this than we did on this image. You can see the nice uniform repeating pattern. And this is typically seen with bony structures. Unfortunately, we can't see really past these bony structures. So when we're evaluating bone on diagnostic ultrasound, we're literally looking at the superficial structures, such as this. Is there any periosteal reactions? Is there any cortical defects that suggest a fracture? Is there any subtle lines that suggest a stress fracture? As all these can be identified on diagnostic ultrasound. So what are the clinical applications for diagnostic ultrasound now that we've talked a little bit about the physics, we talked about how to capture images appropriately, we talked about some of the artifacts that we approach and we can identify tissue. So what do we do with all this in order to help us in musculoskeletal medicine and sports medicine? How do we apply it clinically? Well, as we talked about earlier, the first thing that we can do is we can get dynamic real-time patient feedback images. So this first image on the left is a long axis image. I know it's long axis because I have a tendon, nice compact fibrillar structure coming through here. Okay. I know that I am doing a linear probe because I have a nice flat linear footprint on my screen with a nice square image on the bottom. I know that I'm looking at a joint because I have a nice hyperechoic structure coming across here that then goes into a channel here that then develops another hyperechoic structure. And so this is the metatarsal phalangeal joint of the index finger. And so we're just going to play a quick picture. So this is one of the benefits of it. So dynamically, I'm actively having the patient flex and extend their finger. This is kind of used classically, particularly in the fingers. When we're looking for trigger fingers, you can actually see the tendon getting stuck on the pulley system, although the pulley system is not readily identifiable in this particular slide. But that's one way we can use these clinically. The other way is to kind of see separation of tissues. So as we know in the finger in particular, you have the flexor digitorum superficialis and the flexor digitorum profundus. And so whenever you have pathology in the finger, one of the questions is, well, which muscle is it? Or is it one of them? Is it both of them? So which one is it? So placing this in short axis, because I know I'm short axis now because I'm cutting the muscle tissue or the tendon tissue in half. I have the metacarpal at this point in time in long axis. I know I'm in the finger as well. I have the nice neurovascular structures on both the medial and lateral aspect of the finger with these nice hypoechoic structures. So as this image is played, what I want you to see are the separation of the two muscle bundles or the two tendon bundles here. So if you look between there, as they're flexing the finger, you can see movement of the flexor digitorum superficialis and the flexor digitorum profundus independent of one another. And so if you had a significant injury there, one of the things you could see is only one of the tendon structures moving, and that can kind of isolate where the injury is located at. This can also be very useful kind of distally in the peroneal tendons whenever they're really close and kind of anchored on one another as they cross the distal fibula. So how else is this useful? Probably one of the biggest helps for us is kind of diagnostic ultrasound procedures. It allows us to accurately, move needles, move instruments into anatomical structures with pretty significant accuracy. Multiple studies have shown that there are better outcomes and more improved accuracy using ultrasound guidance for corticosteroid injections and other procedures as compared to palpation guided alone. So in this particular example, I have a long axis view. So it's long axis because I have the femur here. I know it's in long axis. This is the hip joint. The other thing I know that this is a curved linear probe because I have a nice curved footprint on top of here that then forms this nice trapezoidal type pattern as it fans out and gets that larger footprint. The red line here is kind of demonstrating where the needle path is going through here. And the red arrow is going to be pointing to the needle. And once I play the video, you'll see it kind of wiggle. This is the acetabulum coming through here, nice hyperechoic structure. I'm catching a little bit of the labrum here, kind of a little bit off, a little oblique at this time, so I'm not catching the anterior labrum that well. And then I have the hip capsule coming through here and drop in through here. So when I'm doing this image, I'm kind of focusing down and want to make sure I hit that bony structure into the hip capsule. And so on this image, you can see very subtly, but you'll see the needle right there wiggling. And once I do that, I know I'm in the appropriate position. I can deposit whatever medication I'm using at that time. And once I see it go directly into the capsule joint, I know that if the underlying procedure works, it's both diagnostic and therapeutic. And then I know if the procedure doesn't work at that time with this accuracy, then I know we need to be looking at some other tissue structure. In this example, we were trying to differentiate, was this an iliopsoas tendonitis, or was this more of a intra-articular labrum pathology in somebody who had chronic hip pain for a few months. After doing this, we had approximately 70 to 80% resolution after doing this intra-articular hip injection. Subsequently underwent a hip scope, which did show a labral tear that was not identified on the MRI. So how else is it useful for us? So this is another example of procedure. This is going to be a subacromial subdeltoid injection. So on this image here, I have subcutaneous tissue on top. I have a little bit of the deltoid muscle caught at a kind of an oblique angle, so I don't get the nice starry sky pattern that I'm typically looking for. I have the hyperechoic element of the humerus here, and then I have the supraspinatus kind of musculotendinous junction here. So continuing on, this next image is going to be a subacromial subdeltoid injection. This was guided for somebody who had chronic impingement type pain in bilateral shoulders. This just kind of shows a good example of how we can guide our needle and guide our instruments using diagnostic ultrasound to help improve our accuracy with that. Because one of the big things we don't want to do is deposit a lot of corticosteroid into a tendinous structure. So I have the supraspinatus tendon kind of catching an oblique, a little bit of an oblique angle here. I could have optimized this image a little bit better, but I had the hyperechoic humerus right through here. This is the supraspinatus structure here. You have your deltoid and then soft tissue structures above that. What you're going to see is from right to left of image, you're going to see the hyperechoic needle coming in. You're going to see slight deposit of medication into what looks like the tendon. So you're going to see me slowly retract the needle a little bit, and then you'll subsequently see the subacromial subdeltoid bursa kind of open up. And then this next image kind of is a continuation of that. So as you can see, when you first start, it looks like I'm putting it into the tendon because my needle tip's a little bit deep. And so then I just retract a little bit. And then all of a sudden you see kind of this bursa lining open up. And then you see the fluid you see the medication spilling over down into the bursa site. So I know I'm in the bursa at that point in time. So then this next image is kind of continuation of that. So you see kind of the filling of this bursa here opening up and lets me know we're in a good location. The medication's being put in appropriately. So how else is it useful for us? It's helpful for diagnosing pathology. So this image here is going to be an example of myositis ossificans. This is an individual who had a quadriceps contusion back in September. Went about 4 weeks without any treatment, didn't do any flex position, came in for my examination, had diffuse tenderness all along his quadriceps. He had about 85 degrees of knee flexion. This is a kid that wanted to go play college. He's like junior, coming up to his senior year. Got an x-ray, which did show some calcium deposition, but very minimal. So then I decided to pull out the ultrasound and take a look at it. And what I want you to see is the difference between the two. So I have a short axis image here, okay? This is the superficial soft tissue structures with the fascial plane turning into the muscle tissue here. So this is the rectus femoris. And as you can see, it has that nice starry sky pattern that we had earlier. You see the hyperechoic elements with mostly hypoechoic area. So then you have the fascial plane separating the vastus intermedius from the rectus femoris. And then as you can see, once you go past this fascial plane, you lose that nice starry night sky pattern. It becomes very gray, very isoechoic around, which lets me know there's significant soft tissue edema within this muscle tissue because it's lost that normal anatomical structure on ultrasound. The next thing that you're going to see as the image plays, you're going to see these hyperechoic elements creating acoustic shadowing and acoustic artifact. This was useful for me to let me know that this was kind of the rectus femoris was okay and was more guided towards more the vastus intermedius And then I talked to my physical therapist, and we talked about if we're going to target dry needling, if we're going to target soft tissue mobilizations, that we need to hit those deeper structures as opposed to targeting this more superficial rectus femoris. So as you can see here, as this image plays, you see it has this nice starry sky pattern. And then underneath here, like I talked about with the vastus intermedius, you have this multiple hyperechoic areas with posterior acoustic shadowing. And then you have additional hyperechoic areas, all representing calcium deposition consistent with myositis ossificans. One of the benefits of ultrasound when it comes to calcium deposits such as myositis ossificans is ultrasound will pick up these calcific elements before X-ray. And so if you have a high suspicion, clinical suspicion for that, you can get on the board early and start early aggressive treatment with these individuals. So again, this is the same patient. This is just a long axis view. So again, looking at it, you have that nice starry sky pattern of the normal rectus femoris muscle. You got your subcutaneous tissue here. You have a fascial plane separating the rectus femoris to the vastus intermedius. And then you have this kind of isoechoic, homogeneous, not well put together muscle tissue here. And then you have this diffuse hyperechoic band interspersed and interspersed hyperechoic calcium elements all within the tissue with posterior acoustic shadowing. Let me know this is a pretty significant case of myositis ossificans. So we got aggressive with this kid, did about 8 weeks of rehabilitation. He had his full range of motion back after about 8 weeks with aggressive soft tissue mobilization, is overall doing well at this point in time. So how else can we do it? We can, the fact that we can dynamically evaluate people, it allows us to compare contralateral to non-contralateral exam. So if we have an injury to the ATFL in this example, we can always look at the other structure to see what's the difference between those two structures to see if we're truly seeing pathology or if we're seeing some form of anatomical variant. So on this image here, on the left image, I have a normal anterior talofibular ligament. I have the distal fibula tip right here coming down to the talus right here. I have a nice compact fibrillar structure here that's connecting one bone to another bone. So it lets me know this is the ATFL. It's got a nice compact fibrillar structure. I don't see any disruption or anything such as that. So then I move to the other affected extremity. Again, I have my distal fibula tip here. I have my talus here. I'm a little bit more lateral in this image than I would like to be because the talus is a little more flat here as opposed to being a little more rounded. So I could have fixed that. But looking what I see here is I have this fibrillar network pattern right here. And that's what the tissue is supposed to look like. But overall, it's more isoechoic. It has this hypoechoic element in here. You have some increased edema along here. Let me know that there's been an acute sprain of this ligament here. Probably grade 1, grade 2, as I don't see complete disruption of the fibers. Looks like the fibers still continue through there. So probably grade 1, 2 with interspersed areas of hematoma. So it allows me to compare both extremities to see what is the true pathology that I'm seeing on my images. And then again, so this is just another example. This is the anterior inferior iliac spine right before the acetabulum. And so I have both long axis and short axis. This was a soccer kid who came in and started having acute pain after kicking. I believe he was age 12 to 13, 14. So you start thinking, is this an avulsion injury or is this just kind of an acute strain given the mechanism? So the red arrow is pointing to the AIIS, while the green arrow is pointing to the pathological area. You have this nice isoechoic, hyperechoic tendon element coming off. And then that's the rectus femoris muscle belly right here at the musculotendinous junction, followed by the muscle belly there. So as you can see, it's pretty static on this image, but what I want you to pay attention to is this nice hypoechoic cleft within the muscle tendon. That lets me know this is most likely an acute strain. When I'm looking at the bony cortex, I don't see any evidence of cortical disruption. I don't see any evidence of any bone being pulled off, such as an avulsion type pattern. So let me know this is most likely a strain of the rectus femoris as opposed to an avulsion injury. And then, as we talked about earlier, whenever you have pathology in one image, you always want to get pathology in 2 images to confirm what you're seeing. And so this is the same exact image, same exact kid. If you look here kind of on this outside, you have this nice hypoechoic area that correlates with the patient's maximum amount of pain. So consistent with a rectus femoris muscular strain. And then this is another example of procedural guidance. So this is a picture of perineal tenosynovitis. You have your perineal longus here, your perineal brevis here. We're right before the two separate at the sustenanum tau. We're at the point right before they separate in the distal foot at the sustentaculum tali. You see that you have this hyperechoic tendon structure with hypoechoic fluid surrounding it. So normal tendons should not have a hypoechoic fluid structure surrounding it. When you see it circumventing the entire structure, then you start thinking of pathologic features, and particularly in the perineal tendons, most classically is perineal tenosynovitis. If you look very closely here, this is what the normal fibrillar, architecture should look like. So it's more isoechoic, kind of more on this elements, understanding this is a still image. So I would need to see the whole video again to kind of confirm. But when you see this, you get concerned about a possible split tear because I have a hypoechoic element within the middle of the tendon. And you can dynamically evaluate those and sometimes see those when they cannot be identified on MRI. So this same patient decided to do a corticosteroid injection to see for relief. So you have the hyperechoic needle coming in from left to right here in this short axis view of the perineal tendons. You have nice hypoechoic fluid surrounding a pathological tendon, and as well as this tendon as well. The needle sitting in the peritendinous space, and you just inject your medication from there. Again, hyperechoic needle with reverberation artifact let me know that the needle is parallel to the transducer. And then also lets me know that my needle is not directly into the tendon itself, it's in the peritendinous space. And so that way, when I inject my medication, I know we're going to be in the peritendinous sheath. And then finally, this is the last one. I wrote a case report on this back in residency. You can also use it to help evaluate for infectious etiologies. So this is a gentleman, he was about 42, if I recall, came in with finger swelling, finger pain, had all four of the canaval signs. And I said, well, why don't we take a look at it and see what we can see on your ultrasound and see if we can actually see any of the infectious elements from that. So this is short axis again. So as we talked about earlier, I know it's short axis because I'm cutting it in half. I have my hyperechoic phalange here. You're going to see a little bit of the tendon here in this structure. And what I want you to pay attention to is all of this kind of surrounding soft tissue area. And then we'll kind of show it on a long axis as well. But when you look and you're going down, you see that there's mixed areas of kind of hypoechoic and hyperechoic elements, particularly when I get down to this spot right there. When I get to this spot right here, if you look at the tendon itself, you can see there's a little bit of fluid around the tendon. There's some cobblestoning and some isoechoic and hypoechoic elements interspersed with that. And in that setting with peritendinous fluid, that raises suspicion for flexor tenosynovitis. And then I took the subsequent image in long axis. You can actually see a little bit better on the irregularities. So as you see, you have that nice hyperechoic fibrillar pattern of the flexor tendon of the finger. Right above that peritendinous area, you can see very small hypoechoic elements. And then when I go a little bit further down the image, then you start picking up some of this kind of mess right there that shows kind of interspersed hypoechoic purulent material. So we subsequently sent this guy to the operating room where he indeed had MRSA, flexor tenosynovitis. So this pretty much wraps up the lecture. If you really are interested in wanting to get started on, well, where do I go? What are the best ways to talk about, what's the best resource? How are you going about learning diagnostic musculoskeletal ultrasound? I believe the best two articles right now are out would be learning the correct terminology so you understand what other colleagues are talking about. And this is a consensus statement that was just released last month. And this was released by the American College of Ultrasonography, as well as AMSSM and a few other societies that all use diagnostic ultrasound. So they came up with a basic terminology to make sure that we're all using the same terms whenever we're using diagnostic ultrasound. The other one above it, this is the consensus statement by the AMSSM in regards to what do they think needs to be done in regards to be proficient in diagnostic musculoskeletal ultrasound with sports medicine fellows. it just gives a great outline of what is expected on each imaging study in regards to like the shoulder, elbow, knee, et cetera, et cetera. And then for me personally, kind of my Bible when it comes to diagnostic ultrasound is the John Jacobson ultrasound book. I use it every day in clinic. I use it every day when I go home. It's kind of my go-to resource if I'm like, I'm having difficulty getting a good image structure, getting good image quality. What can I do to help improve the images? So this does a great job of going step by step through each one of these on how to identify these anatomic structures. And then it also provides video images on their website where they have about 300 to 400 video clips that you can see that kind of shows different pathology and how to move the transducer and how to optimize your image capture. So those are kind of my go-to from that. Then, of course, any lectures that are available, workshops, conferences, all those type of things to help boost those skills. Here are my references, and I hope this is helpful. And if you're ever interested in diagnostic ultrasound, give me a shout out. Have a great day.